Limb-length discrepancy, we all know, is a thing which can cause nightmares to us and some difficulty in convincing the patient post-op. So what is limb length discrepancy? When the patient has unequal limb length after the surgery of undergoing a total hip replacement, the patient will have unequal limb length and be very unhappy. He might have symptoms like pain, stiffness, difficulty in walking, and a lot of psychosocial problems like depression and anxiety and all. So what is important is, intraoperative challenge for the surgeon is to correct the limb length inequality without compromising stability. We all want a hip to be stable, yet it should be equal to the opposite leg. Or when you're doing bilateral, you want both the hips to be equal length. Both the legs should be equal. So there are various problems which can happen while doing a hip replacement surgery. And if you end up leaving the patient with some discrepancy, especially in the West, the people are trying to get some legal actions against the doctors and extract some money. So same thing, as we know, even our Indian patients are now becoming more and more high demanding, and they also want equal limb length. They want equal treatment. So what are the causes of LLD in THA? So the most important cause is inadequate pre-op planning, implant malpositioning, over-tensioning of the hip, which we all do to avoid any dislocations. We don't want dislocation, which is again a big nightmare. So we try to over-tension the hip, and pelvic obliquity, as we already saw, and the approach. So you can reduce the dislocation by changing the approach. If you are doing a posterior, you can go to an anterior and still reduce the dislocation rate. Also, you can reduce your limb length discrepancy because you can go at the foot end of the patient and measure the limb length. So limb length in conventional THR. When you do a posterior approach or an anterolateral approach, the patient is lying on the lateral position, and it is very difficult for the surgeon to assess whether the limb is exactly equal or not. While if you're doing a supine position, anterior approach, you can still reduce that gap by actually patient is supine, you can go at the foot end and check of the limb length. So it is much safer to do an anterior approach and you can reduce the chance of LLD. Now, what are the consequences of LLD in DA? Patients who have unequal limb lengths will always complain of some backache, abnormal gait, difficulty in walking. There's pelvic tilt, and there are a lot of dissatisfaction is there, and patient not unhappy, is very unhappy, and he also goes around and asks for a revision surgery to some certain extent, and other problems which start with limb length discrepancy. So what is unacceptable limb length? Unacceptable limb length is basically for the surgeon, if it is even more than 5 millimeters, we think it is unequal and we are not happy. But for the patient, if it is shortening of more than 10 millimeters or there's lengthening of more than 6 millimeters, the patient is unhappy. And any LLD more than 10 millimeters, the patient is very unhappy. So this was published by Dr. Desai, and this is what the literature says, that if the LLD is more than 10 millimeters, the patient will be very unhappy. So what are the methods to reduce LLD in THA? One is to do a proper pre-op templating, which is very important, intraoperative measuring devices, then patient positioning. Supine position is always better. You can check the patient at the foot end and feel the malleoli. And then there are various intraoperative fluoroscopy, then there is computer navigation, and lastly robotics. So pre-op templating is very important. So all cases you should do a proper templating of the cup, of the offset, of the vertical and horizontal offset, what stem you're going to use, how much neck cut are you going to take. So this will reduce your post-op limb length discrepancy. Next is lateral position. If your patient is doing a posterior approach or anterolateral approach, your position of the patient should be correct. It should not be moving. The sacrum should be stable during the procedure. You don't want it to move. And correct position involves the surgeon standing behind. And if you're doing an anterolateral, use a leg bag. And that's how your position should be. But there's a lot of eyeballing which is happening when you're doing a posterior or approach in which the patient is lying on the lateral position. So the surgeon is trying to see whether the limb length is equal. He's asking assistant, "Theek dikh raha hai? Is it okay? Am I good? Are we okay? Or how is the limb length?" And you also rely on an anesthetist to just check the sacrum. If the sacrum is perpendicular to the floor, is it tilted forward or backward? Then you try to pull the pelvis behind. So there's a lot of eyeballing happening. So to reduce this further, there are other intraoperative measurements, like you use the vertical offset, which is the AB distance, and the horizontal offset, which is AD distance, to see whether your limb lengths are equal. Still, when the patient is, for this measurement to be equal, you have to make sure the abduction flexion and the rotation of the leg is at the same when you checked it before resection and after resection. So your abduction, flexion, rotation should be same, and you usually end up not putting the patient in the right position. So if your abduction or adduction changes by 5 to 10 degrees, the limb length discrepancy will change by 8 to 17 millimeters, which is a very significant value. And more than 13% of patients undergoing a total hip replacement. So this study has studied that more than 13% patients have limb length discrepancies of more than 10 millimeters. So these 13% patients are very unhappy with the surgery. Now next, to reduce further, you can use fluoroscopy, you can take C-arm shoots, you can see whether your horizontal offset and vertical offset is equal on both the sides if you're doing a bilateral. So these techniques have limitations. The position of femur, the position of sacrum, you have to be very calculative and keep on eyeballing. While in supine position, the patient is supine, you can go to the foot end, but there's one problem with this, it cannot deal with fixed pelvic obliquity. So this is a problem which cannot be tackled except when you use robot. So robot is a newer technique, it uses pre-op CT scans, and it helps in accurate implant placement and reduces the risk of LLD. So what robot does, it helps in placement of the acetabular cup in the safe zone, so you're not going very proximal or distal. It restores your offset, and also it is accurate irrespective of the patient position. If you do it in lateral position or supine, the robot will always be accurate. So there are various studies which say that if you're doing a robotic THR, the discrepancy, the cup position in which ML, AP and superior inferior is within 1 millimeters range, and the cup orientation also is very good, and also the limb length is not more than 1.6. So this is a cadaveric study which was done for 21 patients in which the limb length was not more than 1.6 millimeters. So coming down to that millimeter is very good. Now coming to the big question of spinopelvic obliquity. So this also is very important if you're doing a THR. So that's a simple example. This patient has already undergone a right hip, needs the left hip further. The left hip is 4 millimeters short, but the patient also has pelvic obliquity. So when you see this, actually the patient is short by 25 millimeters. And a scanogram shows there's a 25 millimeters gap. And if you try to see the correction, if you use robotics, you can do actual calculations. Now you're trying to match, and there's a 13 millimeter gap as compared to the opposite hip. And if you plan it, so this is a surgery, post-surgery, you correct it, you bring it back to normal. So you're trying to lengthen not by 4 millimeters, by 13 millimeters to correct the obliquity. And the patient gets a good limb length after the surgery, and the results are very good. So that's how robotics helps in planning and getting the equal limb length. So it's improved accuracy with implant placement, reduced risk of LLD, and shorter surgical time and faster recovery. So that's how robotics helped in THR. Thank you.